Okay. Dissociative identity disorder is a rare condition in which two or more distinct identities are present and alternately take control of an individual. Before a proper diagnosis was formed, people with this condition were described to experience a state of possession. DID was also called multiple personality disorder up until 1994, but then the name was changed to more accurately describe the diagnosis. Because multiple personality disorder states that it's different personalities within a person, it was renamed to show that there are different identities within a person instead of growth of separate personalities. According to the DSM-5, there are 5 distinct diagnostic criteria that must be met to be diagnosed with dissociative identity disorder. Number 1, we have switching between 2 or more distinct alter identities. Number 2 is recurrent amnesia between these alter identities. So when the person has a different identity that takes over, they will forget what was happening in their previous identity. Number 3, the symptoms cause distress and dysfunction within this patient's life. Number 4 is the symptoms are not due to culture, religion, or fantasy. And number 5 is that the symptoms are not due to substance abuse or another pre-existing condition.
So for diagnosis pertaining to dissociative identity disorder, we have ineffective coping related to inadequate coping skills, disturbed thought processes related to childhood trauma or abuse that occurred, a disturbed personal identity related to severe levels of anxiety, and disturbed sensory perception kinesthetic related to threat or self-concept. And for our nursing interventions, non-pharmacologic means, which like pharmacologic means would be if they had stress or PTSD, things like that, that could be treated. But DID currently doesn't have any medications. So we can promote the client's safety, reassure the client with our calming presence. Dissociative behaviors might scare the client, so try to avoid those. Assess for stressors, identify stressors that bring up anxiety in the patient. This is essential in formulating their plan of care, seeing how they respond and such. Number 3, explore the client's feelings. How did the client feel in response to a stressor? Validate that their feelings are acceptable even under severe stress. Encourage methods for coping. Have the client identify methods of coping in the past and determine if the response was adaptive or maladaptive, if it worked or if it didn't work so well. And number 5, enhance the client's self-esteem, provide positive reinforcement for the client's attempts to change their behaviors, and give positive reinforcement. This enhances self-esteem and encourages repetition of desired behaviors.
Go.
I'm going to be discussing the causes of dissociative identity disorder. Research indicates that the cause of DID is likely a psychological response to interpersonal and environmental stresses, particularly during early childhood years, when emotional neglect and abuse may interfere with the personality development. DID cannot form after the age of 6 to 9. This is because children have an integrated self-identity and history. Trauma that occurs later can actually worsen the prognosis of individuals with DID. The types of trauma that occur are child abuse, child neglect, and disorganized attachment. This is usually when the caregiver serves as a source of comfort and fear, and the child relies on the parent but is also fearful of the parent due to abuse or neglect. There's actually 2 spots of physiological abnormalities in the brain for DID. It is the hippocampus, and this is usually, it deals with memory and evaluating context in a child's surroundings. So this takes the first 3 years of life, and if there's trauma or anything, that never really develops, doesn't develop all the way. And then it's the orbitofrontal cortex, and this is the emotional processing, self-regulation, and helps with decision making and self-reflectiveness. And that usually is disturbed in people with DID. And usually each area is smaller than a normal person's would be.
This is triggers and what you'll see in people with a dissociative identity disorder. People with DID may have episodes of DID to be triggered by a variety of real and symbolic traumas. Those traumas can include a minor traffic accident, a certain illness or stress. Reminders of past trauma can also trigger a dissociative episode. The person with the DID may or may not be aware of the other personality states and memories at the time when an alter is dominant. meaning a person can remember one personality and not the other. An episode of amnesia usually occurs suddenly, and you may see the person have an episode that can last minutes, hours, and rarely months.
Right.
Okay, are there treatment for patients with DID, psychotherapy, cognitive behavioral therapy, and family therapy? There are no medication to treat patients with DID themselves. However, people with DID that associate with depression or anxiety may benefit from treatment with such as antidepressant or anti-anxiety medication. I have 3 points about treatment. Psychotherapy is the main treatment for patients with DID. Cognitive therapy focused on changing dysfunctional thinking pattern, feeling, and behavior. Family therapy helps teach the family member about the disorder in order for them to have a better understanding, as well as recognize the symptoms for reassure. Also, they can also participate in creative therapy such as music and art.
Symptoms of dissociative identity disorder can often present themselves as memory loss, also referred to as amnesia, of certain time periods, events, people, and personal information. A sense of being detached from yourself and your emotions, a perception of the other people and things around you as distorted and unreal, also a blurred sense of identity. Significant stress or problems in your relationship or work or other important areas of your life can also be impacted. An ability to cope with emotional or professional stress, and also mental health problems such as depression, anxiety, and suicidal thoughts and behaviors. DID often presents itself as covert and difficult to notice, with only 5 to 6% of individuals having DID having a more florid presentation. Switching between alters is rarely accompanied by dramatic shifts in personality that are highlighted by changes in clothing, preferences, and accent. According to the DSM-5, individuals who are diagnosed with DID often first present to clinicians with comorbid disease. The symptoms might be mistaken for mood disorders such as bipolar disorders or major depressive disorder, personality disorders such as borderline personality disorder, psychotic disorders such as schizophrenia, other dissociative disorders such as other unspecified dissociative disorders. The DSM-5 warns that 70% of outpatients with DID have attempted suicide, that some but not other alters may self-harm or have suicidal thoughts or ideations. Urges complicates treatment.
So a really interesting facet about dissociative identity disorder is that people can have different types of personalities that present themselves in the form of what are called alters. And these include common types such as a child role, a persecutor role, protector, suicidal or sexual, and then less common roles like animal, baby or infant role, demonic, ghostly or spirit-like, or an authority figure. Alters vary greatly. They can differ by age, gender, names, the role a person sees themselves in, a different perception of their appearance, memories, trauma, or life events that may have happened.
So our first alter is going to be the protector. There are alters who protect the body, system, host, core, or other specific alters or groups of alters. Physical protectors might take or try to prevent physical abuse or become aggressive in an attempt to defend physical abuse. Emotional protectors might take emotional abuse or comfort each other's alters to soften the effects of emotional abuse. Sexual protectors might take sexual abuse or attempt to instigate sexual abuse in an attempt to feel more in control of themselves and the situation.
The second role, I'm doing the persecutor. Persecutor or alter who purposely harm the body, symptoms, host, core, or other alters, sabotage the system goal or healing, or work with assist to the system abuser. Persecutor might hold self-hatred or provide an outlet for individualized abuse or negative messages. They also may believe that hurting the symptoms or other alters is the only way to control them or teach them how to behave, and so prevent further to more extreme abuse from outside abuser.
Our next one is the introject. Introjects are alters who are based off of an outside person or figure. Introjects can be based off a family member or adult caretaker who supported the dissociative child and provided a positive influence in their life, serving as a source of potential positive messages for the child to internalize. Introjectors can also be based off of historical figures that are the dissociative child found strong, courageous, or heroic, or otherwise worthy of being internalized or like a hero in their life.
Okay, memory holders. Memory holders are alters who hold memories that are usually traumatic in nature, so that other alters do not have to be confronted by the memories. Other times, memory holders might hold memories of childhood innocence or of being loved by the system's otherwise abusive or neglectful family. In these latter cases, the memory holder might serve to preserve these memories untainted by memories of trauma or to avoid confronting the system with the pain of what the abuse has caused to them.
A gatekeeper. A gatekeeper is an alter who controls switching or access to front, access to inside, or access to certain areas inside, or finally access to certain alters or memories. The existence of a gatekeeper is highly stabilizing for a system because gatekeepers can, to some extent, prevent unwanted switching. Failure to switch when necessary or failure to switch to the correct alter. They can help to prevent traumatic memories from bleeding from the alters who hold them to alters who cannot yet handle them. Internal self-helper. An internal self-helper is an adult who holds vast amounts of knowledge about the system, alters, trauma, and/or internal workings. For those who believe in cores, internal self-helpers are often viewed as the first alter to be created, whereas the normally pseudo-separate internal voice of logic and reason that all people possess.
And the last one we're going to talk about is the fragment. A fragment is an alter that is not fully differentiated or developed. Fragments may exist to carry out a single function or job, or to help a single memory or emotion, or to represent a single idea. Depending on the way that the individual system uses the term, a fragment might be any alter that could not survive if left on its own, or that could not pass for a fully developed individual without the help of the other alters.
We're going to go into the patient's room. His name is Bob Williams. He's a 22-year-old male. He came in for a car accident, and as of right now, he has a broken femur.
Does he have any injury, any brain injury? Did you guys have the MRI done?
Yes, we had the MRI done, but it shows no brain damage. I also took a look at his toxicology screen, and that is coming out clean. He is free of alcohol and drugs in his system.
Did you ask him if he have any pain? What was his pain level?
He is in some type of pain, so I will be administering some medication. He seems to be also a bit confused because I asked him what his name was, and he keeps changing his name and date of birth.
Okay, so we should go ahead and have a talk with him.
Okay. Knock, knock.
Come in.
Okay, hi, I will be your nurse today. My name is Rosario Ortiz. Can you please state your name and date of birth?
Bob Williams, 9/13/1997.
Okay, are you in any pain today?
A little bit, yeah.
Okay, that might be the fractured femur.
Oh, okay.
Do you know how you got here today?
Yeah, an ambulance took me.
Okay. All right, well, I will be back with the pain medication, and I will see you shortly.
Okay, thank you.
So I have looked at the patient, but according to my paperwork, when he first got admitted, he claimed he was Zane Woods. When I went in the patient's room, he properly has stated that his name was Bob Williams, and according to my paperwork, is Bob Williams, so I will now begin to administer his pain medication due to the fact that he got his name correct.
Come in.
Hello, Mr. Bob Williams. I am here ready to give you your medication for morphine. Can you please state your name and date of birth one more time for me?
It's Taylor Williams, April 18th, 2001. But yeah, so that way
Are you
you're
sure he's a student?
ready for.
Yeah, I'm sure.
They wanna like
May
go
you
off the medication.
Do you know who Bob Williams is?
He's an idiot.
That's a very,
I will be right back with the morphine medication.
No, we don't need morphine. He deserves to be in pain. He's the idiot that got us in the car wreck.
Give me 1 second. I will be right back. I will speak to the doctor, and we will be right back.
Okay.
There's-
What was that about? Who was that?
I'm being like.
Knock, knock. Hello, my name is Roselli. I will be your nurse today. I have brought the student nurse with me, and she will be taking your vital signs to make sure everything's okay.
What sign?
A vital sign.
What's that?
It's
Hi, my name is Swedlin. I'm the student nurse today. The vital sign is where I take your blood pressure, your temperature, and your oxygen. Can you please tell me your name and your date of birth?
My name's Addie, and my birthday is May 22nd, 2012.
Okay, thank you.
So that thing's not going to squeeze my arm?
No, ma'am.
Oh no? Why not?
It'll be just
It's
a
just a
slight
little pain.
pressure, but it's not enough to hurt you. We're not here to harm you.
Okay. No shots?
No shots, ma'am.
Then I guess it's fine. You can put it on me.
Alright.
Okay, listen here. I need to take your body, okay? Because I know you're over here playing around. Give me your arms.
What are you talking about? We don't even want to be here. Why are you doing this?
I need to take his vitals. He seems like he's playing. I don't have time.
I'm not playing around. I don't even know why I'm here.
Who is you?
My name is Ashley Miller. I'm 18 years old and I don't know why I'm here right now.
Knock, knock.
Come in.
Hi. You remember me? I'm your nurse, Ruth. I was just wondering what happened. I heard there was some type of issues going on when they were trying your blood pressure on.
Yes. I think that
I like them. I don't think
I actually
You
forgot
came in here and
to mention I actually have
fine.
DID
I like them.
and
They
I
squeeze
have
my arm. It was fine.
different voices that
You're
come
threatening. I don't want to be
to
here.
speak
You're
out.
everything for me to be
I was
here.
just taking his vitals.
Sometimes it just really affects me and I lose control and these other personalities, they kind of come out. My
Okay.
psychologist calls them alters.
Okay, how do you feel right now? Are you okay?
Yeah, I just told him to stop and to just go away.
Okay, we're gonna head out. We're gonna leave you a moment so you can be okay, and we don't want to overwhelm you. That's not what we want to do while we're here.
Okay, thank you. I know that you're doing your best practice.
You're welcome, sir.
A 55-year-old woman presented with substance abuse and a comorbid bipolar disorder. She presented to the hospital with multiple personalities after being under the influence of substances and other things. Her alters included a female child, a teenager, a male alter, and her own self, the host. She only became aware of her alters after outsiders informed her after each situation that she couldn't really remember. She said that this trigger, like a trigger for her, was stress and substances, actually. They were involuntary and she lacked memory from the event. Her child alter would cry and hurt herself when things did not go the way she wanted. Her teenage self was very self-destructive. She was abused substances and she was even violent and sometimes homicidal. Her speech was pressured during this state and repeated many words and phrases and didn't really make that much sense. The male alter actually seemed like a male. He had a deeper voice, perception of male body parts, and was sexually attracted to other females. The patient informed the team that severe anxiety was experienced between transitions, and she actually sometimes had a migraine before she transitioned. She was prescribed citalopram for her anxiety and began cognitive behavioral therapy to help with substance abuse. But there is no cure for dissociative identity disorder through medication. It's just talk therapy. But yeah, that was our case study.
The cause of dissociative identity disorder is believed to be a result of severe physical and sexual abuse, particularly during childhood. It is found to be a combination of self-hypnosis, a fantasy-prone personality, or a desire to escape child abuse through pretending that someone else was experiencing the abuse in their place.
This was until they were able to create an alter who could then actually do it. Studies show that when years pass by and the alters are used more and more, each one becomes more individualized and strengthens. This also causes more amnesia to form with each alter transition. There is also a very strong correlation between this particular condition, DID, and substance abuse, as people may use drugs or alcohol to numb symptoms and separate from reality. People may use substances as a way to cope with their victimization and past trauma. Individuals with dissociative identity disorder and co-occurring addictions contend with added difficulties on top of original issues that led to the disassociation. Disassociation and addiction are both chronic, recurring conditions that are complex to treat. In one study of people in an inpatient substance abuse treatment program, over 17.2% of people had a dissociative disorder of some nature. Most importantly, treatment is vital, as over 70% of DID patients attempt suicide and self-harm due to the internal conflict. Cognitive behavioral therapy is the recommended treatment option when referring a patient for talk therapy. Additionally, psychotherapy, another form of therapy, can span from 5 to 7 years. Individuals who do not receive treatment tend to get worse, as alternate personalities cannot integrate on their own. Untreated dissociative identity disorders make an individual susceptible to further exploitation and mistreatment by others. Typical treatment approaches attempt to stabilize an individual, process trauma, and integrate personalities. Like we saw in the case study, there are currently no medications known to fix dissociative identity disorder, but medications can actually be used to help with anxiety and other coexisting conditions like PTSD and things that accompany DID.